Hi there, this is Dr. Sid Wayangankar from Jacksonville, from the Baptist Heart Specialist. And welcome to a cloudy afternoon from Jacksonville. And we'll be talking about a topic that's very close to my heart. I am a structural interventional cardiologist working for Baptist Cardiology. And the topic that's close to my heart, as I said, is transcatheter structural interventions. We're talking about the ABCs of structural interventions. And as I said, usually I'm an interventional cardiologist. In layman term, it means the plumber of the heart. What traditionally the field started as being putting stents in the coronary arteries, we call that coronary interventions, has slowly grown to starting to fix arteries of the legs, the kidney arteries, the neck arteries, which are the peripheral arterial disease, and therefore when we fix blockages in these arteries, those are called peripheral interventions. And finally, in the last decade, there has been a huge growth in trying to fix the structure of the heart. And when I talk the structure of the heart, it's the valves, if there's a hole in the heart that needs to be fixed, if there is too much heart muscle that needs to be removed, or there are dead spaces within the heart where clot gets accumulated and can cause stroke. So trying to fill up those dead spaces. So when we look at all these procedures that are focused on fixing the structure of the heart, that's called structural interventions. And basically what we are looking at, those type of interventional cardiologists that do structural interventionalists are called structural interventional cardiologists. So now as we speak, the interventional cardiology has grown into coronary interventions, peripheral interventions, and structural interventions. What we're going to talk about today is the latter. And I think in the comments section, I have a slide that kind of outlines the agenda of what we're going to talk. The title of the talk says transcatheter structural intervention. So as you can imagine that these procedures that we do, unlike surgeons, these are not open heart procedures. That means you don't have an incision on your chest. They don't crack open your chest. We actually do these procedures through minimally invasive route, usually through a needle hole. And through this needle hole, we are able to pass our wires, our balloons, our devices that go through these catheters, and therefore the name transcatheter therapies for structural interventions or transcatheter structural interventions. So the way I have divided this talk is, let's look at the heart in general. As we know, we have four valves. Two on the right, which are the tricuspid and the pulmonary valve. We have two on the left, which is the mitral and the aortic valve. And both the valves could be native, that means what we are born with, or they could be surgical. That means that patients who have had previous problems with their native valves had open heart surgeries, and the surgical valve was placed in them. So what can possibly go wrong with native valves? So there are basically two problems that can happen. One is the valves can get narrow, stenosed, and therefore there will be damming of blood before the valve, and they just fail to work, or they become too leaky. So either stenosed or leaky, or narrowed or leaky. So these are the two problems that can happen. And the therapies are designed to fix either one of them. Okay, now I will be talking about first the ones that are FDA approved. The most commonest and the first thing that ever came out actually was to fix a narrow mitral valve. The mitral valve is a valve that allows the blood to flow from the left atrium to the left ventricle. And I say it was one of the earliest therapies because the therapy that was used to fix a narrow mitral valve, and we are talking of the conditions that usually were more seen in third world countries, and we're talking of rheumatic fever. And people who have had rheumatic fever as kids sometimes can develop rheumatic heart disease, a part of which is narrowing of the mitral valve, and patients can present in their 30s and 40s with symptoms of mitral stenosis. The valve becomes so narrow that it appears like a fish mouth, And therefore the therapy was that we went through the veins of the leg, we put wires and balloons from the right side, went to the left side of the heart by poking a hole through the septum, and we put bigger sized balloons through this fish hole, which was the narrow mitral valve. We would expand the balloons and try to open the valve by causing minor tears in the valve. So in doing that, we would open the narrow hole, but we would also lead to some kind of leakage. But because the stenosed valve would open up, patients' symptoms would get better, and some of these patients did well for 5 to 10 years, and then they would eventually narrow again, and then they would come back and people would balloon it again. And this technology has been there for about more than 20 to 30 years and has been routinely used to treat symptomatic severe mitral stenosis, and it is still being used. Now this is called a transcatheter mitral valve repair, because remember, we have not replaced the valve. Then we will talk about mitral. Since we are on mitral valve, I will talk about leakage. Let's talk about if the mitral valve leaks. So one of the newer therapies that have come out is called a mitral valve clip. So what happens in leakage is the mitral valve has 2 leaflets, and if there is a problem with either the leaflet or the chamber that is below the leaflet called the left ventricle, the valve starts leaking. And when it starts leaking, it leads to a lot of blood flowing from the left ventricle into the left atrium instead of flowing out of the heart. That leads to patients having shortness of breath, atrial fibrillation, and all other problems. Normally, the standard of care right now for patients is to get an open heart surgery and get the mitral valve repaired or replaced. But in patients who are high risk for surgery, we have a therapy called the Mitra clip, which is basically, in layman terms, a clip that we used to we hang it to dry clothes in several parts of the country. When we dry clothes in sunlight. Same design of the clip. We go from the groin vein. We go with our devices and catheters from the right side of the heart, poke through the septum into the left side, grab the 2 leaflets that are malfunctioning and clip them together. In order to, a bigger hole like this will become 2 small holes, and your leakage is then decreased, thereby leading to improvement in symptoms, heart failure symptoms, and decreased hospitalization. Again, bear in mind that this is only approved currently for patients who are at high surgical risk and cannot get an open heart surgery to fix the leakage in mitral valve. Coming next to the aortic valve, which is the gatekeeper valve. Why is it the gatekeeper valve? Because that's the valve that ejects the blood from the left ventricle to all parts of your body. 2 things can happen, again, leakage or narrowing. The most commonest is the narrowing, which we call aortic stenosis. It's a disease of aging, and as we age, aortic stenosis becomes more prominent. This is a disease that actually presents as exertional shortness of breath, exertional chest pain, or exertional lightheadedness. We have evidence to show that if you have severe aortic stenosis and if you have any of these 3 symptoms, if the valve replacement is not done, then your life expectancy is less than 5 years. And this data has been known for years, and therefore open heart surgery with replacement of aortic valve was recommended since at least 3 to 4 decades. About a decade ago, we had a therapy called as TAVR or TAVI, which is transcatheter aortic valve replacement. Again, before this came out, we always had balloon aortic valvuloplasty, just like the mitral side. If the valve is narrow, we can go in with a balloon and crack it open. The problem with the balloon strategies are that they don't last. So the transcatheter repair with a balloon helps the patient, but they do not last. The benefit doesn't last for more than 3 to 6 months. And therefore, the replacement is a more definitive way of treating these valves. What we do in a TAVR procedure, and I recommend each one of my audiences to to Google or do a YouTube search of TAVR, and you'll have several animations of the two valves that we use to replace. Actually, there are three now in the market, three companies that make it. But essentially, the idea is that we go from a groin artery through a needle hole. We advance a balloon. We crack open the narrow valve, make space for a bigger valve to come in, and we put a bigger valve in with a balloon, or sometimes they are self-expanding. There are two technologies out there. We replace the valve and come out of the same needle hole, and this is done with the patient completely awake, not under general anesthesia. There is not an incision on the chest, and as long as there are no complications, patients can go home the next day and resume work within a couple of days without any major restrictions. This has really been a game changer since its inception, and as more evidence came up, this was initially approved for patients only with high risk for surgery, but then as the evidence became so strong, now the TAVR procedure is recommended for all comers. So all patients with severe aortic stenosis who have one of the three symptoms I talked about are candidates for a TAVR or a TAVR procedure. And it's approved for all patients, low risk, high risk, intermediate risk for surgery. So something that has been really a game changer in the therapy of structural heart disease. Then the other two valves, which are the tricuspid and the pulmonary valve, the usual interventions in pulmonary valve are mainly on the pediatric side, kids who have some congenital defects. So I'm going to put that aside for the sake of discussion in today's talk. But the tricuspid valve is the other valve, and we don't have any approved technology right now to fix the leakage in the tricuspid valve or narrowing in the tricuspid valve. The devices are there that have been used off label, stuff like the clip that's used on the left side has been used on the right side, but these are not yet approved. These are at the experimental stages, and there are several other new devices coming in the pipeline that may help address problems of the tricuspid valve. So essentially, for the native valves, what we have is treatment for leakage of mitral valve, like a replacement. We have a repair for mitral valve stenosis. We have repair for aortic valve stenosis, which is almost now obsolete because we have a definitive form of treatment for aortic valve stenosis in the form of valve replacement in the form of TAVR procedure. Now, the other thing that can happen is patients may have surgical valves previously placed in them, and as you know, the surgical valves which are placed during an open heart surgery, they can last about 10 to 15 years at best, and then they degenerate, and they again can degenerate either by leaking or by narrowing. The good thing about that is we could use the TAVR valves that we used in aortic position. We can use that same valve, the same technology, to fix any of the valves in the heart. And right now we have FDA approval to fix aortic surgical valves with a TAVR valve and mitral surgical valves with an aortic TAVR prosthesis. We call them valve in valve. So basically there's already a surgical valve and you put a TAVR valve inside it. So that's a valve in valve procedure. So FDA has approved that for aortic valve in valve and mitral valve in valve. So patients who have aortic surgical valves, mitral surgical valves, and now they have become dysfunctional, they don't need another surgery. We can just have a new procedure done with minimally invasive route, and the patient can go home the next day without an incision on the chest. For the tricuspid position, if somebody has a tricuspid ring or a valve, we can still do the TAVR procedure, but currently it's as an off-label use and not FDA approved. Now, this is about the valve in general if there's a dysfunction. Now, what if there are, when the surgeons put the valve in or later after surgery, sometimes there may be gaps between the tissue of the heart and the surgical valve. So if you're looking at a surgical valve and this is the heart tissue, you can imagine there is a hole between the surgical valve, which is this, and let's imagine my right hand is the tissue, the cardiac tissue. You can see a C-shaped hole just between the surgical valve and the tissue. We call this a leak, but the leak is perivalvular or paravalvular. That means it's around the surgical valve. The problem is nothing to do with the valve, but maybe the tissue has regressed, or there was always a hole that has become bigger, and now the blood is leaking from outside the valve. The traditional way of teaching of treating this would have been just to have another open heart surgery where they crack open your chest again. And I would say 70 to 80% of the patients, by the time they have this, or because of age or comorbidities or the facilities that they have around them, are not a candidate for such kind of procedures. Luckily, we have minimally invasive routes of treating that, where we go through veins or arteries depending on which valve it is, and what we do is we try to cross that hole, which is right here. We cross that hole with wires and catheters and put plugs inside them. By basically, in layman terms, we just plug the holes with wires and devices which are usually 1 to 2 millimeters or 3 millimeters in diameter, and that pretty much takes care of the problem. The leakage goes away and patients start feeling much better. Usually patients with paravalvular leak present with either hemolysis, that means that red blood cells are kind of getting destroyed going through that, that tight hole around the valve, or they may have what we call congestive heart failure. So that is one another modality of transcatheter interventions, where it's really helpful for patients who have had one surgery, then they have a paravalvular leak, and then we are plugging it in later instead of the patient undergoing a high risk second redo open heart surgery. Then I'm going to talk about patients who have what we call hypertrophic cardiomyopathy. This is usually a genetic problem where patients, when they grow to their teenagehood or 20s and 30s, the wall between the two ventricles, which we call the ventricular septum, that becomes very thick, and when it becomes thick, it causes obstruction to flow of blood from the left ventricle into the aorta. The traditional way of treating that was do an open heart surgery and chop off that excessive muscle or thick septum. Again, over the last 2 decades, there have been several studies to show this novel technology which we call alcohol septal ablation. The principle is that we try to locate the branch of the artery that supplies that particular thick muscle, which is the culprit, the problem. And based on our skills of wiring, and we try to wire that specific branch of that artery, we put a balloon on top of it, and once we have isolated that artery, we put some chemicals to make sure that particular thick muscle lights up. And then when we are confident that is that thick muscle, we inject 100% alcohol and destroy that artery which supplies that abnormal thick muscle selectively, and we cause a selective heart attack. We create a heart attack to eventually destroy that excessive thick muscle. This procedure is called alcohol septal ablation. I have been doing this procedure for the last 3 to 4 years with excellent success, and we have been able to avoid open heart surgeries for patients with excessive thick hearts, which we call hypertrophic cardiomyopathy, with excellent success rate. Now, another technology that I'd like to briefly talk about is called left atrial appendage closure. As you know, there are certain things there are certain areas of the heart that basically have less function. We call them sometimes vestigial organs or vestigial segments of the heart. One of them, which is formed during embryogenesis, when we are in our mother's womb, is called the left atrial appendage. Normally, it's like an outpouching in your left atrium, and normally it does not cause any concerns because every time a heart beats, the top chamber squeezes and the lower chamber squeezes. So there is good flushing of all the chambers of the heart, right? But sometimes in conditions like atrial fibrillation, where the top chamber of the heart, instead of squeezing, it just kind of quivers. And when it quivers, there is pooling of blood in the top chamber of the heart, especially in this pouch, which we call the left atrial appendage. And when there is pooling of blood, there is layering of the blood and eventually clot formation. And that clot formation can then, that clot can migrate to the left ventricle and then form a, and present as a stroke, which is very disabling. Traditionally, we have been treating patients with atrial fibrillation with blood thinners, and that is usually the standard of care. But there are patients who take blood thinners and then they have concerns of GI bleed or bleeding in the brain and stuff like that. When patients cannot tolerate blood thinners or are high risk for bleeding from blood thinners, this is an option where we put in devices into that pouch. The current one we use is the Watchman device, and we basically close that hole. And once that hole is closed, then even if the patient has atrial fibrillation, there is the clot that's formed in that left atrial appendage is blocked off by this device, and the future risk of stroke are mitigated. Another device that can be used is Lariat, which is basically tries to do the same thing, but it comes from outside and cinches off that left atrial appendage. The final thing I'm going to talk about is PFO closure, which is not actually described in my slide there, which is basically a hole between the two top chambers of your heart. It's called the atrial septum, and it's actually not a hole, it's a flap, and about 20% of us have that. When we are in our mother's womb, the roof grows down and the floor grows up, and they kind of remain like this. As you can see, the flap, and that is the connection between the mother and the baby. When we are born, this flap closes down in 80% of us. In 20% of us, it remains open. So there is an open connection between the right and the left side of the heart. This can either be in the form of a PFO, where it's like a flap, or it can be as a big defect where the growth is stunted and there's a bigger hole. That's called an ASD, so atrial septal defect, or PFO, that is patent foramen ovale. In either ways, it's a connection between the right and the left side of the heart. For specifically talking of PFOs, which is present in 20% of us, we routinely don't need to close it, but now we have current evidence that shows if somebody has a stroke, which is not explained by any other feature, we call it a cryptogenic stroke. And the theory is that a clot from the veins of the leg traveled to the right side of the heart, passed through that hole, went to the left side, and caused a stroke. So basically, in order to prevent these future events in patients like these, we close this hole again with wires and devices that go through the veins of your groin artery via the needle hole. The procedure is about a 30 to 45 minute procedure. We watch the patients, they're completely awake during the procedure. We watch them overnight and they go home the next day without an open heart surgery. That pretty much rounds up like a brief overview of structural heart disease and the transcatheter interventions that we have to offer for patients with these structural heart disease in the current era. Again, I'm Dr. Sid Wayangankar from Baptist Heart Specialist. I'm available to answer any questions if anybody has them. I see the first question I have is, what can I do day to day to avoid structural heart issues? Unlike coronary artery disease, where lifestyle has a big factor, unfortunately, structural heart disease in general is usually, I would say, not preventable. If you look at the conditions we are talking about, like PFO, we are born with it, right? Then we have aortic stenosis. It's a disease of the aging, right? There are certain conditions like mitral stenosis, which is basically rheumatic mitral stenosis, that we can avoid if people have rheumatic fever in childhood, should be treated aggressively with penicillin. But other than that, unfortunately, structural heart disease is usually a disease that comes with aging, or maybe affected by genetics or something that you're born with, and then eventually when you have problems with it, we try to fix it. But what you can definitely do is, of course, have regular visits with your physicians. If somebody has told you have one kind of structural heart disease, not all of them need treatment. Remember, what I talked about these structural heart disease are these conditions when they are severe and they are symptomatic. In fact, what we see is just the tip of the iceberg. The bottom of the iceberg have the conditions but don't have the symptoms. If you don't have the symptoms, then you really don't need to be doing anything. So regular visits with your physicians. When you're diagnosed, regular visits with your cardiologist. I would prefer a structural heart disease specialist. And when the symptoms come up and when there is an indication, then come and see us and we'd be happy to help you. Yes, the other question is any procedure for left ventricular hypertrophy. Now, if the left ventricular hypertrophy is diffuse, that means all around, it usually comes from hypertension, long-standing hypertension. And for that, we usually like to treat it with medications only, which are essentially to treat hypertension and lifestyle modification, weight loss and hypertension control and stuff like that. Patients who have hypertrophic cardiomyopathy, which has some genetic component to it, has various variants. Some of it is apical, some of them is diffuse, as you said. We don't have any therapy for them. Recently, there is a medication that came out, which there was a recent trial about it, but it has still not started in mainstream whether we can use that medication or not. Again, even that medication, even the myectomy, and even the alcohol septal ablation that I talked about is specifically reserved for this specific thickening in the heart or the hypertrophy in the heart, which is subaortic in the septum, in the proximal part of the septum. We call it idiopathic hypertrophic subaortic stenosis, IHSS, or HOCM, which is hypertrophic cardiomyopathy, but it has to be subaortic and not diffuse. All right. If you have no more questions, thank you so much. And we are available at downtown campus. Please contact us and we'd be happy to take care of you. Thank you.